Hello, my name is Mirrakhimov. I'm one of the cardiac anesthesiologists at the University of Kentucky. Today we'll be discussing ABA basic exam review topic on physics, principles, properties, and laws. And here's my email. I have no conflict of interest in regards to this presentation. Our agenda for today is to discuss mechanics, flow velocities, flow meters, properties of liquids, gases, and vapors, gas laws, and principles of Doppler ultrasound. And again, we'll not be discussing other ultrasound topics, but rather focus on the Doppler effect. Here's an important disclaimer. The clinical case scenarios which are presented in this talk are for educational purposes only. Any resemblance to real individuals or medical situations is purely coincidental. Do not use this information as a substitute for professional medical advice, diagnosis, or treatment. Always consult with a qualified healthcare provider regarding your specific medical concerns. Let's talk about mechanics and how we measure pressure of gases and liquids. On the mathematical level, pressure equals the amount of force exerted over a certain area. Pressure can be measured in different units, one of them being Pascal, which equals about 1 Newton force over squared meter. Also, we can utilize centimeters of water, millimeters of mercury, pounds per square inch or PSI, and atmosphere. It is important to know that 1 atmosphere equals roughly 760 millimeters of mercury, which equals about 988 centimeters of water, which equals about 14.7 psi, and which equals about 101.3 kilopascal. And here on this pictorial, you can see that the gas exerting a certain amount of pressure on the walls of a container. So let's talk a little bit about the manometers. They're commonly used to measure pressure. It utilizes a column of fluid which can be either water or mercury, and the pressure which is exerted will move the fluid and then the difference be measured. It is important to note that manometers work best by measuring pressure that changes relatively slowly, and they're not practical to measure high pressures because the amount of fluid which is necessary or needed for that is impractical. So when we need to measure high pressures, we commonly utilize what is called a Bourdon gauge, and I'll show you a couple of examples. So here you can see the manometer, and in terms of the pressure difference, we see different height of a liquid is in the tube. And here, this is an example of what is called a Bourdon gauge. And again, we typically see that on our oxygen tanks or some other gas tanks because it is more helpful in measuring higher pressures. Pressure regulators, or also known as pressure reducing valves. Modern pressure regulators have three main components, such as shown here on this picture, including the spring connected to a diaphragm and connected to a valve controlling the high pressure gas input. Based on the principle that large forces acting on the small areas, which is a valve in this case, can be balanced by small forces acting on large areas, or a diaphragm in this case. Let's do a question. We have a 35-year-old female who is in the operating room for cholecystectomy. She is uneventfully intubated and mechanically ventilated with 70% FiO2. Suddenly, you notice that your inspired oxygen started to downtrend and is currently 24%. You suspect a central pipeline gas supply failure. What's your immediate next step? Option number one, you disconnect her from the anesthesia machine and manually ventilate through this BVM or back valve mask, which you connected to the auxiliary oxygen source on the anesthesia machine. Option number 2, you open the backup oxygen cylinder on the back of the anesthesia machine. And option number 3, you open the backup oxygen cylinder and disconnect the anesthesia machine from the central pipeline gas supply. So let's go through the answer. So there are different sources of oxygen and medical gases to the anesthesia machine, with the main being central source, delivered via pipelines. The pipeline pressure is roughly close to 55 psi, whereas gas cylinders pressures is decreased to about 45 psi. So unless you disconnect the pipelines, you will keep giving the pipeline source. So the right answer is to disconnect from the pipeline source and open the oxygen tank on the back of the anesthesia machine. So what are the safety concerns and how we can minimize the risk of giving the wrong gas to the patient? Obviously, there is a pin indexed safety system, or PIS, which is used for cylinders. Make sure that the wrong cylinder is not attached. And there's also a diameter indexed safety system, or DIS, to make sure the right gas is connected to the pipeline. Unfortunately, these are not foolproof. There's always a possibility of having a central oxygen supply error, or the cylinders can be filled with the wrong gas, or sometimes you can have a damaged yoke pins and being able to attach the wrong gas to the anesthesia machine. So let's talk about gas cylinders. In anesthesia and clinical medicine, we commonly utilize so-called E-cylinders. And here on the top right, you can see different sizes of cylinders. The gas behavior is governed by the gas critical temperature. So what is a critical temperature? It is a temperature below which the gas becomes liquid. For example, the critical temperature for oxygen is about minus 119 Celsius, and the critical temperature for nitrous oxide is about 36.5 Celsius. And again, to minimize errors, the cylinders for each gas are color-coded. So let's keep talking about gas cylinders, and we'll briefly discuss the three main gases we use in anesthesia in medicine, such as oxygen, air, and nitrous oxide. In this country, the United States, the color-coded is green for oxygen, yellow for air, and blue for nitrous oxide. The color-coded may be different for other countries. What is a PSI, or pressure of a full cylinder? For oxygen and air, it's about 2000 psi, and for nitrous oxide, it's about 745. So what about the physical state of a gas in a cylinder? For oxygen and air, it's about gas. For nitrous oxide, it's a mixture between liquid and vapor. What's the volume of a full cylinder? For oxygen and air, it's about 625 to 700 liters, depending on the source you read. And for nitrous oxide, it's about 1590 liters. It's important to note that since nitrous oxide is stored as both liquid and vapor, the pressure will only start to fall when about 20% of the mixture is left in the cylinder. Again, it's hard to know for us how much gas is left in a nitrous oxide cylinder unless the pressure starts falling down. That's when we know that the cylinder is close to being empty. So let's talk a little bit about pressure transducers. In the clinical practice of anesthesiology and critical care medicine, we commonly place arterial lines, central venous catheters, pulmonary artery catheters, and also quite often monitor intracranial pressure or spinal pressure. On the right side of the slide, you see a representation of a so-called Wheatstone bridge. Wheatstone bridge is basically used in modern pressure transducers. Wheatstone bridge uses the current across three known resistors to determine the force unknown resistor, which is the transducer itself. So let's talk about zeroing and leveling. So why do we need these two? Zeroing is typically done to exclude the impact of the atmospheric pressure. Proper leveling for the most indications is typically done in the force intercostal space in the mid-axillary line. For certain surgeries or indications, such as brain surgery, the transducer may be placed at a different level, for example, at the external auditory meatus, to better measure the pressure in the brain. It is important to note that if the level is placed too low, the actual pressure reported will not only include the patient's pressure, but also will add the hydrostatic pressure in the fluid column of the transducer system itself. So let's do a question. You have a patient who is undergoing shoulder surgery in the beach chair position. He has non-invasive blood pressure cuff in place, which is about 30 centimeters below the external auditory meatus. His most recent blood pressure measurement is 120/70 with a mean pressure of 87. The question is, what is the approximate cerebral mean arterial pressure? Option number A, 82, option number B, 60, option number C, 65, and option number D, 73. So let's go through the answer. It is important to note that the estimate for every 10 centimeter height difference of the transducer is about 7.4 millimeters of mercury difference. So remember that there is a 30 centimeter difference between the blood pressure cuff and the external auditory meatus. So you multiply 3 by 7.4 and you get about 22.2 millimeters of mercury. And again, recall that the patient's MAP was 87. So 87 minus 22.8 equals 64.8, or approximately 65. So 65 is his approximate cerebral mean arterial pressure. So let's talk about resonance and damping. So the definition of resonance is when the natural frequency of the system is met with the same natural frequency which is applied to the system. So the resonance tends to distort the electrical signal, and hyperresonance systems, specifically in arterial monitoring, result in higher SBP, lower diastolic pressure, and increase in pulse pressure. So it is important for us to understand what is the natural frequency of the system. The natural frequency of the system is the rate at which the system moves or oscillates. What about the fundamental frequency? And in regards to arterial line, it is the lowest frequency and it is equal to heart rate for all intents and purposes. When the heart rate approaches the natural frequency of the system, of the measuring system, it is considered to be at its resonance frequency. And again, the natural frequency measures the oscillation of the system, whereas damping measures how quickly the system gets to rest or comes back to rest. So the monitoring systems should have higher natural frequency to minimize the resonance effect. And damping is being used to decrease the signal amplitude. So let's talk about the factors which both increase the frequency and also increase the damping. So short tubing, less compliant tubing, larger diameter of the tubing, and lower fluid density increase natural frequency of the system. What about damping? Longer tubing, highly compliant tubing, narrow tubing, kinks in the tubing, bubbles, clots, arterial vasospasm, and three-way stopcocks, they all increase the damping of the system. And again, let's take a look at some examples. What can you do to see whether your system is under or over dampened? We can do what is called a flash test. When after the flash test we only see 1.5 to 2 oscillations, which is considered normal, over-dampened system will have less than 1.5 oscillations, and under-dampened system will have more than 2 oscillations. Typically, the mean arterial pressure for both under and over-dampened systems will be about the same. However, the systolic pressure will be slightly higher for under-dampened system, and the diastolic pressure will be slightly higher for the over-dampened system. So let's talk about flow and velocity. In simple terms, the flow can be described as the amount of volume of a certain substance over a certain period of time, whereas velocity is the distance traveled divided by the time. So what about this next formula, where Q is the amount of volume equal the pressure difference, or delta P, at different sides of the tubing, which is relevant to our practice, and divided by the resistance to flow. So next formula is basically Hagen-Poiseuille equation, where letter R is a resistance, Greek letter eta represents viscosity, letter L represents tubing lengths, P is a number 3.14, and R to the fourth power represents the radius. It is relevant to our practice because longer tubing, more viscous fluids will have a slower flow rate due to higher resistance, whereas catheters with larger diameter radii will have a faster flow rate. And the next formula also represents a modification of Hagen-Poiseuille equation. Again, the flow can be viewed as the delta P, or pressure difference, times PR to the fourth power divided by 8 times viscosity times lengths. Let's do a question. We have a 2-month-old premature infant with post-extubation stridor, which is unfortunately refractory to mainstream treatments. And the infant is started on Heliox, which is a mixture of helium and oxygen. So the question is, which respiratory effect is most likely to occur as a result of this intervention? Option A, increased inhaled gas viscosity. Option B, reduction of inhaled gas density. C, predominance of non-laminar flow. And D, improved distal airway bronchodilation. So let's go through the answer. The density of helix is lower than the density of air, or oxygen, but its viscosity is about the same. And helix has no direct effect on the airway tone. So the correct answer was related to lower density. So let's talk a little bit about the laminar versus turbulent flow. In laminar flow, the fluid or gas moves in numerous thin layers, which are also known as streamlines. Typically, the velocity is highest at the center and it's lowest at the periphery. Turbulent flow, in comparison, is quite different. The direction of flow in turbulent pattern is quite erratic. Unlike laminar flow, the turbulent flow has non-linear relationship between the flow and the pressure. For example, to increase the flow of gas or fluid twofold, the pressure gradient must increase by 4 times, or fourfold. That is a major reason why turbulent flows are less efficient, and they do require a higher energy to generate and maintain. So let's talk a little bit about laminar turbulent flow and so-called Reynolds number. The Reynolds number formula is basically the multiplication of the density of the gas or fluid times the flow velocity times the diameter of the orifice divided by the substance viscosity. The Reynolds number of less than 2000 is typically associated with laminar flows, versus the Reynolds number of more than 4000 is typically associated with turbulent flows. And on the top of this slide, you see different factors which promote laminar versus turbulent flow. So let's talk about medical gas density, since we had a patient earlier who benefited from the heliox. As you can see here on this slide, the density of helium is much lower than the density of nitrogen, air, and oxygen. Helix is typically a mixture of 79% helium and 21% of oxygen. It has similar viscosity but lower density compared to air and oxygen. Its lower density promotes laminar flow and potentially improves respiratory muscle work and delays respiratory muscle fatigue. Again, it is important to note that helix by itself doesn't cure or reverse the process. However, it may buy or give you additional time so that the other therapies may have time to work. So let's talk about the concept of pressure recovery. It is a part of so-called conservation of energy. For our purposes, we will discuss the potential energy and the kinetic energy. The kinetic energy is motion related. For example, you are driving the car or you're on the train. The potential energy is the stored energy related to the object position. For example, a book sitting on the bookshelf. Here's an example in regards to echocardiography. For example, in the stenotic aortic valve, when the blood passes the tight orifice, the kinetic energy or the velocity decreases. However, this energy gets converted into the potential energy, and after passing the area of obstruction or tight aortic valve, the potential energy goes back and reverts into kinetic energy, and the pressure recovers. So let's talk about so-called Venturi effect. The higher flow rates, which occur through the narrow portion, can create negative pressures at that point. This concept is utilized in Venturi masks and nebulizers. For example, in Venturi masks, the room air gets entrained at a lower pressure point at the mask's nozzle due to the high flow of oxygen. The nozzle itself has an adjustable aperture that sets the entrainment ratio and hence the aspired FiO2, which you provide to the patient. And here on this pictorial, you see eccentric mitral regurgitation jet representing the Coanda effect. The Coanda effect occurs because of the higher velocity and lower pressures. So let's talk about the flow meters, which basically represents the glass tube that we use to gauge the amount of fresh gas we deliver to the patient. The flow meter, or the first generation flow meter, which is presented in this picture, is called a Thorpe tube, which has a variable orifice, a flow measurement scale, and a ball or bobbin. The bobbin is used to understand how much flow we are delivering to the patient. And again, it's important to remind us that the flow meters are part of low pressure systems. The walls are much closer to the bobbin near the bottom of the glass tube versus as the bobbin rises top, the walls are getting farther away, allowing for higher flows. The ball or bobbin stops rising or falling when the delta pressure above and below equals its weight. Again, it is important to know that each tube is calibrated for a specific gas given different densities and obviously different temperatures. The flows which we measure will not be accurate if the tube is not vertical, or there is a leak in the system, or if a different gas is being used because of the density, or if the bobbin or ball itself sticks to the walls of the tube. So again, on this slide, especially on the left part of the screen, we have what is called transitional flow meter. And in transitional flow meter, the gas flow is controlled mechanically with electronic display, but it also has a common glass tube, like in the first generation. Again, every gas is color-coded. Again, just to remind us, yellow for air, green for oxygen, and blue for nitrous oxide. And the newest flow meters are purely electronic, where the gas delivery is controlled fully mechanically without a glass tube, like the one shown on the right. So let's keep talking about the flow meters. The actual flow versus the set flow rate may be different. Again, maybe because the gas has slightly different density. Also, most anesthesia machines compensate for temperature because with higher temperatures, the gas tends to expand, and which is opposite with lower temperatures. Barometric pressure is also important because, as you may remember, if the pressure goes up, the volume of gas goes down, and the opposite is true as well. Let's also talk a little bit about the safety features which are present in most, if not all, modern anesthesia machines. On the right part of the slide, you see a Link 25 system. The Link 25 systems, they physically link the control knobs of oxygen and nitrous oxide flow meters, which turn down the nitrous oxide when the oxygen flow is decreased. This is used to minimize the risk of administering a hypoxic gas mixture. So let's talk a little bit about the properties of liquids, gases, and vapors. There are three main phases, which include gas, liquid, and solid. The liquid and gas, they do occupy the same volume. So what about the surface tension? Surface tension is a property of liquids which allow them to assume a shape that has the least amount of surface area. The surface tension is created by so-called van der Waals forces, which are the sum of attractive and repulsive forces between molecules. So here we'll talk about cohesive forces, adhesive forces, viscosity, and the boiling point. Cohesive forces represent an attraction between particles of the same type, whereas adhesive forces represent an attraction between particles of different types. Viscosity can be seen or thought of as how thick the fluid or gas is, or how sticky it is. And again, on the top part of the slide, you see the different flow of water versus glycerin. And obviously you can assume here, based on this pictorial, that the glycerin has higher viscosity. So what about the boiling point? The boiling point occurs when the vapor pressure equals the barometric or atmospheric pressure. For example, at a high altitude, the water will be boiling at a lower temperature due to lower atmospheric pressure. Let's talk about critical pressure, critical temperature, and a vapor pressure. Critical pressure is a pressure above which the matter can only exist as liquid, no matter what the temperature is. Critical temperature is a temperature above which the matter can only exist as gas, no matter how much pressure is exerted on the substance. What about the vapor pressure? Recall that our volatile anesthetics represent a gas or vapor and a liquid phase. The gas or molecules evaporate from the liquid phase and exert some pressure on the container, which is called a vapor pressure. When the vapor is in equilibrium with the liquid phase at a certain temperature, it is called a saturated vapor pressure. Here in the table, you see different volatile anesthetics with their respective saturated vapor pressures. And also note the boiling point of different volatile anesthetics. Here we'll start talking about gas laws. Gas laws is a common and frequently tested topic on ABA basic examination. And this sometimes can be difficult for us to fully understand and can be quite stressful. So there are different gas laws which we'll talk about. The Charles law. The Charles law can be used to determine the volume or temperature of a given substance when the pressure is constant. For example, during cold weather or in winter, sometimes your car will alarm that the tire pressure is low. And this is because at the lower temperatures, the gas will decrease its volume and potentially lead to lower pressure exerted on the tire. The way I remember the Charles law is related to the temperature is C in Charles law stands for C in Celsius. There are some other gas laws which we need to know for the exam. One being the Boyle law, which is used to determine the volume or pressure of a given substance while we maintain the same temperature. The way I think about Boyle's law is B stands for barometric or pressure. One real-life example is when you fly an airplane, sometimes you notice some discomfort in your ear or difficulty in hearing, for example. And this happens because at lower pressure, the gas tends to expand. That is why patients with recent pneumothorax, for example, are discouraged from flying a plane. Again, because the gas will tend to expand. The Gay-Lussac law is very similar to Charles' law. The main difference between the Charles law and the Gay-Lussac law was in the experiment. For example, the container in Charles' law was flexible, whereas it was rigid in the Gay-Lussac experiment. Let's briefly discuss Dalton's law. Dalton's law states that the partial pressure of a gas in a mixture of gases is a pressure that the gas would exert if it occupied the total volume of the mixture alone. And in this formula, P equals partial pressure of gas, PB is atmospheric pressure, PH2O is a water vapor pressure at a given temperature, and letter F stands for fractional concentration of a gas. So let's answer a question. We have a 45-year-old male who is breathing room air in Denver, Colorado. The atmospheric pressure in Denver, Colorado is about 632 millimeters of mercury. So what is the partial pressure of oxygen in this patient's trachea, assuming that he breathes in room air? Here's the answer. 632, which is atmospheric pressure in Denver, Colorado, minus 47, which is a vapor pressure of water at 37 degrees Celsius, times 0.21 or 21% of fraction of inspired oxygen or room air. And the answer is 123. So the derivation of Dalton's formula can be used in alveolar gas equation. The formula is partial pressure of alveolar oxygen equals to the barometric pressure or atmospheric pressure minus water vapor pressure times the fraction of inspired oxygen minus partial pressure of carbon dioxide divided by R. And R represents a respiratory quotient, which is the ratio of CO2 production to oxygen consumption. and in most cases it can be assumed that the R is 0.8. AA gradient, or alveolar arterial gradient, can aid in the workup of hypoxemic states. For example, hypoxemia with normal AA gradient typically represents a hypoventilatory state, such as opioid overdose, for example, or low expired oxygen, or high altitude or low barometric pressure. For example, hypoxemias with high A gradients typically are due to VQ mismatch, ventilation-perfusion mismatch, shunt, or diffusion limitation. Because the A gradient will normally increase with age, it is important for us to compensate for age when we evaluate patients with hypoxemia. One formula which may be useful equals 2.5 plus 0.21 times age in years. Again, 2.5 plus 0.21 times age in years. For example, let's assume we're seeing a 100-year-old patient who is otherwise healthy, and we want to know what's his normal age-adjusted AA gradient. So the formula is 2.5 plus 0.21 times 100, which is 21 plus 2.5, which equals 23.5, which is age-adjusted AA gradient for a 100-year-old patient of ours. Let's talk a little bit about the Henry's law. It helps us to understand the concentration of a dissolved gas. And the concentration of the gas equals to the pressure of the gas times the gas solubility. In clinical medicine, or somewhat closer to clinical medicine, Henry's law helps us to understand how oxygen dissolves into deoxygenated blood in the lungs. And this occurs due to pressure gradients, because the partial pressure of oxygen is much higher in the alveoli than in deoxygenated blood. And again, similarly, with our inhalational anesthetics and volatile anesthetics, it helps us to explain how the concentration of anesthetic agent in the blood is related to the concentration in the alveoli. Finally, let's talk about Doppler ultrasound. As a cardiac anesthesiologist, this is a very important topic for me. Doppler shift measures the change in frequency reflected by a moving object. With Doppler, we can examine the direction, velocity, and the pattern of blood flow in clinical medicine. The equation for Doppler is presented on the bottom of the screen. The delta Doppler, or Doppler shift, equals the velocity of blood flow times the cosine theta, which is the angle between the ultrasound beam and blood flow, times 2 transmitted frequency. And why we have 2 transmitted frequency? Because we have a frequency which was transmitted and a frequency which was returned from the moving object, divided by c, which is the velocity or speed of sound in a tissue, and we assume it is 1540 or 1540 meters per second. So let's talk about the cosine theta, or the angle between the ultrasound beam and the blood flow. So ideally, you want to have this cosine theta as 0, which will fully allow you to measure the true velocity. So the higher the cosine theta angle, the less reflective of the true velocity your measurement will be. For example, when the cosine theta is 90 degrees, you'll not be able to measure any Doppler shift, not because it doesn't exist, but rather because you cannot detect it. For example, on the right part of the screen, you have parasternal long axis view on the top and the apical 5-chamber view on the bottom of transthoracic echo. We typically measure the LVOT diameter, or left ventricular outflow diameter, in the parasternal long axis view. But because of the Doppler alignment angle, you will not be able to detect an accurate velocities. Rather, you would use an apical 5-chamber view, which has much better alignment with the Doppler angle. That's why we use apical 5-chamber views to measure LVOT velocities. Let's talk a little bit about the pulse wave Doppler, or PWD. What it does, it sends out an ultrasound beam in short pulses and listens to the returning signal when not transmitting. It has some advantages and some disadvantages. The main advantage is its ability to precisely locate the Doppler shift. The disadvantage is aliasing. So aliasing occurs when the actual velocity is higher than the ability of the pulse wave Doppler to accurately measure. Aliasing occurs when the pulse repetition frequency is not twice the Doppler shift of the returning echo. So what are some of the ways you can do to decrease aliasing artifact? First, you can use a lower frequency transducer via increase in pulse repetition frequency. You can reduce the depths of the interrogation area, and what it does, it increases the pulse repetition frequency. And obviously, if nothing else works, you can use the continuous wave Doppler, which we'll talk about in a little bit. So let's talk about color flow Doppler, which is a form of pulse wave Doppler. What about BART? I'm not talking about Bart Simpson's here, but rather it's a mnemonic or abbreviation for blue away and red towards, which means blue signal is going away from the probe or transducer and red signal going towards. It doesn't have anything to do with the venous flow or arterial flow. So let's talk about the power Doppler, which is a variant of a color flow Doppler or a pulse wave Doppler. The power Doppler signifies the presence of a Doppler shift. However, it doesn't tell you the direction or the speed of the Doppler shift. What are some of the advantages of power Doppler? It has higher sensitivity to low flow states. It is unaffected by angle, unless it is exactly 90 degrees. It's unaffected by the aliasing velocity. The disadvantages include lower frame rates or image quality. You cannot measure the velocity or direction of the flow, and is susceptible to motion artifact when you move the transducer in soft tissue, when you see a burst of color or flash artifact. So like promised, let's talk about continuous wave Doppler, or CWD. The transducer of a continuous wave Doppler has two crystals. One is constantly transmitting and one is constantly listening or receiving. It has several advantages and disadvantages. The main advantage is that you can measure any high velocities, and there is no aliasing artifact as seen in pulse wave Doppler. However, because you don't know exactly where the Doppler shift is happening, it has a range ambiguity problem, which means that you don't exactly know where the Doppler shift is occurring. In conclusion, obviously everything we do in life and anesthesia in clinical medicine has some foundation in physics. We are more likely to be tested on physics applications to patient safety and patient care, rather than pure physical laws and properties. It is important for you to remember the safety mechanisms of our anesthesia equipment and some of the limitations. And finally, thank you very much for your attention, and good luck on the test and in real life. Thank you.